Vortioxetine, remember the reference, I have taken it from product monograph. Okay, and also from four of the articles which I'll be quoting along with the author's name. Those articles are the post market surveillance article. Okay, those are there because you it's a recent molecule. It's a recent means since like it hasn't been like it wasn't in the year 2001 when it was being developed, and later on the FDA approval for treatment of depression came in 13. So it has been around in the market after approval for 10 to 12 years. So post market surveillance you need to know. That is why vortioxetine is still being asked, because it's the surveillance keeps on going. Okay, so without any delay, let's start with it. First important thing is I'll just ask you, what is the class? To which class does it belongs to? Anyone would like to answer to which class does it belong to? So if you don't know, no issues. Let's start. Serotonin modulator, very good. And something you need to add on to it. Serotonin modulator and stimulator. That is why it is called as a multimodal antidepressant. Okay, next. Who developed this? See, the development was done by Merck, big pharma name, Merck, and Glaxo, Smith, Klein. This was done in 2001. And later on, multiple companies came in, but last it was Forest Laboratories. Okay, and after the application, it got approved by FDA in 2013. Okay, now let's start with pharmacokinetics directly. So please remember, it's not an SSRI. It's not an SSRI. Always remember this. Fine. Now see, I have been prescribing vortioxetine a lot since last 6 months. That is the duration since I have started my own clinics. Prior to that, when I was an SR, I used to prescribe it specifically to the young population, ranging from 20 to 35, 40. Okay. Now, one important complaint which was there that you all must have also heard about this is nausea, vomiting. Okay. Please keep an asterisk to this. We'll come back to this when we'll read the side effects. First of all, let's start with the pharmacokinetics. If you ask about pharmacokinetics, there is no significant effect of food on absorption. Okay. The bioavailability is 75%. After this, If you look, let's look into the metabolism. Now, before that also, let's look into this. So the peak serum concentration, it comes in 7 to 11 hours. And steady state plasma is reached in 14 days. You can remember this also if you want. Else, the most important part is coming this, that it is being metabolized by the important ones are CYP, 2D6. Three of you, the things you need to know, 3A4 slash 3A5. Remember all those CYP enzymes which was utilized by clozapine, olanzapine, CYP2C9, CYP2C19, and 2B6. 2B6 is utilized by which antidepressant? Anyone? The name of the antidepressant starts with B only. Yep. So correct. Okay, bupropion. After this, if you look into the T half, very good T half, 66 hours, quite a long T half. Now, excretion to kidney. Let's keep only the details which you need to know. Okay, done with this. Now, after this, let's look into, okay, FDA approval. Just add 1 point for major depressive disorder. Now, let's look into pharmacodynamics. Now, see, exact mechanism of action is still not known. However, it increases the release of several different neurotransmitters, in which you need to know serotonin, norepinephrine, dopamine. So it is acting like an SSRI. Along with that, it is acting like an SNRI also. SSRI property there, SNRI property, it is also there. And remember the two extra thing that it also works via, it is also helping through other means also. Glutamate, acetyl, choline. I'm writing it separately because all of you know the frontal cortex and the region of hippocampus, the memory formation part requires these two neurotransmitters. Okay, that is why although it increases the level of serotonin, norepinephrine, dopamine, that is what is having similar action. In addition to this, these are the two extra thing. Also, there is increase of histamine. Yeah, cognitive domains are addressed. Now, do you just let me know what does histamine do? Histamine makes you sleepy or antihistaminics makes you sleepy? So antihistaminics make sleepy. Rather, it is increasing histamine. So kind of activating agent is present. Not strong, but kind of activating. So it's better preferred to give it during the daytime because of this. However, if the patient says that no, it's okay, this part is not doing or interfering with his or her routine work, you can give it anytime, no issue. Now, if you look into this, some of the antagonist actions have been directly noticed. Strong antagonist at serotonin reuptake, 5-HT, 3, ST7. Okay. And then there is a partial agonist action, 5-HT, 1A, 5-HT, 1B. These are well documented. Remember them. For others, we still don't have that much of idea. Okay. Also, one more thing. Remember, the studies are coming up which shows that it decreases GABA. It decreases GABA. Fine. Now, if you look into the plethora of this, like at times you feel very how can I say, at times you feel very limited as far as the choice of antidepressants are concerned. At times you have too many choices. But if you look into the buffet of antipsychotic antidepressant, multiple studies have shown that there is a pro-cognitive effect greater than a comparator antidepressant in patients with major depressive disorder as far as vortioxetine is concerned. Now, however, the problem is depression. Please write it down. Let's look into reality. Depression is a symptom cluster. That is why it's a disorder. I hope now, after attending so many sessions, you are clear with what is disease, disorder, illness, isn't it? Okay. Now, so depression is a symptom cluster, and in this there is a symptom where itself is a where itself, if you can note, there is impairment in cognition. Suppose an agent starts working on the symptom cluster of depression, and there is decrease in symptom which marks improvement in cognitive domain. That is quite obvious. Any agent, I'm just saying. Is it clear to you? I'm saying that any agent, if you give for depression, in depression already there is impairment of cognition. If you give, there will be reduction in symptom of depression. There will be improvement in the cognitive domain. Okay, so standing there, it's impossible to attribute that any specific improvement on cognitive abilities to a drug itself is there. Okay, but still it is being promoted like this as a having a pro-cognitive effect. One more thing, a controversial one, still you should know. Now see, you have seen multiple head-to-head trials. Okay, have you seen this? I'm slightly deviating the topic, but it will take hardly 5 minutes. See, If I compare vortioxetine versus escitalopram, is it a legit comparison? Just think, is it a legit comparison? It's like comparing apple with orange. Is this comparison correct? Just let me know if is this comparison correct? Apple with orange. Can you compare apple with orange? Or you can compare Himachal Kinnori apple with Kashmiri apple. Can you compare this? Can you do this comparison, the second one? This you have said it is not possible. Can you do this, the second one? Because both of them are apple, their characteristics will be different. Similarly, vortioxetine is a totally different set of molecule as compared to escitalopram, which is a totally different set of molecule as compared to venlafaxine, which is a totally different set of molecule as compared to be it trazodone, be it bupropion. So that is why there is so many paper. If you read for vortioxetine, it says that it's a this cognitive domain thing, that pro-cognitive action is a false thing. It's just a bogus. Okay, it's a fluke. They are just promoting it. So remember that the head-to-head trials which have been done, they are done through, they have compared molecules, each with having different properties. So that is why you need to be very much cautious if you're reading any meta-analysis. Look into what studies have been included. However, some trials have shown a positive result in geriatric depression. Okay, positive result in elderly population. There is also a claim which was done by the company that it prevents recurrent depression. Still, we are not sure about this. It's just a claim. If you read the site, it will say this. Now, yes, very good, Bhavya. For comparison of this type, should the performance of the different drug against placebo should be considered? That is how whole thing starts. First, there are animal trials. Then there are human trials. In the human trials, what do? You start with the human trials. The first trial will be like, for example, I'm doing for vortioxetine. Let's compare it with placebo. That's the first thing. And that thing goes into the market saying that this agent is showing improvement as compared to placebo. That is the first thing, and that is what makes a company big. It starts launching news, it starts giving, you know, lectures, conferences were going on that such and such kind of thing is going on, and ultimately we are getting such kind of results. Now, the real thing is that with the current going antidepressant, which is the most popular one in the market, like for example, antidepressant number one is there, and I am promoting escitalopram. We know that acetalopram is a simple molecule which acts only on serotonin and nothing else. So what do we do? We are actually doing a very wrong comparison. This molecule has a wide span of action. It can act on a lot of uh, receptor, and instead of knowing that fact, we are comparing it with a molecule which acts on only a few set of receptor. Again, you will see that there will be an improvement that can be noted. Okay, so such kind of comparison which goes on head to head trial, even after doing it with placebo, placebo gives only one thing, that if you are not giving any drug versus if you are giving the drug, how much impact this drug is making, whether this drug is making any impact or not, or is it doing the other way around. It means that is it doing some effect or not. Okay. Now see, I mean for this pro-cognitive claim, if we compare the performance of different drugs against placebo and then decide, for example, 20% better performance against placebo versus 20% better performance against placebo. Now see, that is what you can do. What you can do is, see, you can do a placebo control trial, which is very commonly done, also done for vortioxetine also. That if you do apply the scale for cognitive assessment, for example, you have applied MOCA. You have applied MOCA to the person who is taking vortioxetine, and you have applied MOCA who is on placebo. This will assess the cognitive domain, but you know that cognitive domain itself is not an independent kind of thing. The mood, speed of processing, everything is a whole symptom domain. So it might affect this assessment also. But whatever result is getting, that is why they say that upon applying or upon assessing upon a scale which assesses cognition, we have got positive result as far as cognitive domain is concerned. Okay, so definitely this is one of the ways by which you can popularize your molecule, and you can say that this is way better. But how to make a justification in this scenario when you're doing it with escitalopram? How to make a justification if you're doing it with venlafaxine? Whether that is doing same or not, because the molecules are completely different. That becomes a big question. Okay, so I hope this is clear to you. Now, there is another point that was mentioned is vortioxetine. If you look into the NICE guidelines, it is actually given in the third line. First trial of SSRI, second trial of SSRI, and then you go for metas, vortioxetine. Remember? So there it has been mentioned as vortioxetine. So they say that it is vortioxetine that needs to be done to be given before labeling a patient as TRD. After this, they say that if the patient doesn't respond to the third option also, you can go for the assessment as TRD. So vortioxetine, by this, why it has been kept low? Okay, usually we don't query this. Why in this guideline also they have kept it low? Because it has been claimed because of unique multimodal action, that all those people who do not respond to the usual antidepressants, a trial of vortioxetine can be given. Although it is not a dictum, but it can be given. Okay. Now let's look into the indications. The one indication for which it has been FDA approved is major depressive disorder. Other indications are generalized anxiety disorder, cognitive symptom, which are the residual symptom in depression, and of course, as you know, geriatric depression. What is the dosing? What is the dose range? Come on. Similar to estalopram. That is the dose range. Correct, Pranchi. In what formulation it comes? It comes as 5 mg tablet, 10 mg tablet, 20 mg tablet. Some companies also release 15 mg, but these are the common one. How to initiate? Anyone would like to answer how to initiate? Okay, start with 5. What about others? Now see, the initial thing is initial 10 mg can be started, or initial 5 mg can be started. According to the patient, you can decide what you need to do. Okay. Now 10 mg, if you're starting with the 10 mg one, then increase to 15 mg, and then you increase to 20 mg. What is the time duration which is being said for which it needs to be increased? Up titration definitely needs to be done. How to increase? Okay, so usually what the company recommends is a weekly increment. If you're starting with 5 mg, you can come up to this. Remember, one more thing, do not crush, divide, or dissolve the tablet. It's a small tablet. It no it comes in this shape, tear shaped, very unique shape, tear shaped tablet. Okay, all of the tablets are round. Usually, this is how the tablets are. For this, it's a tear shaped tablet. If you haven't seen, I'll show you. I have one Vortioxetine here. Okay, so it's like a seed or a tear. Okay, how to show you? Okay, it's a seed or a tear. Can you see this? Okay, it's not round. It's like a seed. Okay, remember that. That is, it's look like an orange pip. You can say it. It's like a seed only. It's like a seed or a tear. Okay, that is how it is. Fine. That is what you're exciting. Not a completely round. It's not completely round. Fine. Now, it's not like this. It's like this. Now, most of the people they have this nausea vomiting kind of thing. So the company or not, the package insert doesn't say this, although the company says that you can start with domperidone, and then after giving domperidone you can take half hour, and then you can give vortioxetine. Okay. Also, if you're giving at night, you can say that you can take it at after meals. That also can be given to decrease that sensation. It's a rate limiting. It's a actually it's a self limiting side effect. Nausea and vomiting is a self limiting side effect. Remember this. The key thing was this, the shape. Remember. Now, if you are given it, how to taper? How to taper? Okay, before answering this, tell me, how do you taper fluoxetine? How do you taper to fluoxetine? All of you, come on. Suppose you have placed me on 80 mg of fluoxetine. How do you taper it? Come on, think. If I'm asking this, this has to be a different kind of question. How do you taper fluoxetine? Okay, suppose I'm taking alcohol and I've been taking around 50 around you know 300 ml of alcohol daily. You started me on chloride epoxide and I stopped following up. How to taper chlor diazepoxide? Yes, Elsa, you're correct. You're actually going in the very correct direction. That these are all long-acting agents. Fluoxetine. What is the T half of fluoxetine? It lasts for 7 days itself, my dear. What is the T half of chlordiazepoxide? The T half of chlordiazepoxide. If you look into and if you count all the metabolites, it is just around 200 hours. So suppose on day one you have given me 150 mg of chlordiazepoxide and I stopped coming to you because of some issue. Although I have stopped taking the medication, the alcohol and medication both. Remember, if you start, you can you can stop it instantaneously. You don't need to taper in that manner. Okay. What usually the guideline says, which Ankur is also saying, this is what the guideline says, tapering guidelines. Tapering guideline says to taper antidepressant, you can decrease by 20% and you can select the day. It ranges from 2 to 7 days according to the patient. But remember, for long acting ones, like for fluoxetine, you can stop, self taper will happen. 80 mg, if you stop today, also self tapering will happen. This also is having a T half of 66 hours. This is also having an additional benefit of having no withdrawal symptoms as opposed to venlafaxine. Withdrawal symptom with venlafaxine is noted. So you can decrease the dose then and there only. It's always better to decrease on weekly basis. Okay, or you can follow 20% decrease rate ranging from 2 to 7 days. Okay, now let's look into some of the drug interactions. Important one. In the drug interaction, tramadol and vortioxetine is a no because it decreases threshold of seizure. There are interactions of vortioxetine seen with triptans. Okay, Suma specific, sumatriptan. Suminat, it comes in the name of Suminat, it comes as Suma self. Sumatriptan. Okay, sumatriptan, it comes as a tablet, 50 mg, 80 mg, and there is, okay, I'm writing the brand name, but I'm not associated with this company. Suminat. There is only one company which brings nasal spray also. That is called as Suma Self. La Renon is a company which actually brings Suma Self. Okay. With this, there can be in coordination in movement. So you have to keep a check. Okay. All of you know that there is a time gap when you give MAM inhibitors and this, the same thing, the common interaction that goes for all the antidepressants. So we are not writing it here. Okay. Now in special population, let's see. Special population, renal impairment. You don't need to do it. Don't need to do any change. Even with the minimal functioning, it can come out. Hepatic impairment, mild, moderate, no change. In severe, data is still coming up. Limited data. Cardiac, whatever data has been recovered as of now, no impairment has been noted. In elderly, no dose requirement, no dose adjustment. Only thing, keep a check on serum sodium because of what? Why we need to keep a check on serum sodium? Because of risk of SIADH. Okay, SIADH is very common with these antidepressants. So you need to keep a check on serum sodium. Child and pregnant females not evaluated. So no data as of now. Now, breastfeeding, still not evaluated. Let's look for the side effects, the common one and the rare one. Common. Common one is very, one thing is nausea, constipation, vomiting. Next, you have sexual dysfunction, slightly, but yes, it is present. There are reports of weight gain also, but this is only in reports. Okay. Next, rare seizure. Only remember this seizure. That is why I asked you to keep a check with tramadol. Okay. Now, studies after release. Let's see what is the scenario. Three or four studies we'll see. We'll see from 2021. Most of these studies were, and the same thing has been replicated in 2024. So the original study I'll list. Bishop et al. In this study, they compared vortioxetine. They actually assessed vortioxetine for elderly in older adults for cognitive effect. They found that promising result is present in elderly with depression. Okay. Now, next was Loveno et al. This was again in 21 study. Okay. Now, this is what you mentioned, Bhavya. Conduct meta-analysis, meta-analysis of vortioxetine in adults with MDD. Remember, it says that vortioxetine is more effective than placebo. In what domains? In anxiety, in cognition, and in depression. Okay. So I hope you have got the your answer, Bhavya. This is one of the uh, trials which was done comparing it with placebo. Okay. Now, one more trial I'll quote. Adelino, Adelino et al. 22. What they did, they actually review reviewed and gathered data on vortioxetine from 2015. That is 2 year post launch. It was launched in 13. So from 2015 till 2020, they gathered data, and what they found, their findings are that improvement in both depression and cognition symptom. They attributed it to the unique multimodal mechanism. They also said that because of this unique multimodal mechanism, the new mechanism, I'm just writing it in a different way. They say that it can be responsible for its effects on cognitive functioning and improved tolerability profile. This study also mentioned three things: anti analgesic, anti inflammatory, analgesic, this was noted in preclinical trials. Okay, this whole review gave one thing, that it can be used in depression concomitant with menopause symptom, pain, inflammation, apathy, sleep, or metabolic abnormalities. Okay, recently in 2024, of the topic, it was being utilized to decrease size of glioblastoma multiforme. Which is a tumor because vortioxetine crosses blood-brain barrier in a very significant manner. Now, since these were the preclinical findings of analgesics, we are what is effect of it was something preclinicals which they are doing. There is nothing that can cure GBM. Okay, it is just it can reduce the size and something like that. Okay, I'll just have to check it also because that kind of thing has not yet come up. Now, vortioxetine as a new frontier for treatment in chronic neuropathic pain. Okay, this has also come up. And when you look into this, when you look into this, remember, being an antagonist at 5 5-HT3 postsynaptic receptor, specifically at the spinal cord, dorsal horn of spinal cord. And it fully occupies this. It decreases hyperalgesia. Okay. And thus was used for pain control. I'll share this article. It came in 2024, last year. Okay. Next, it inhibits 5-HT7 receptor. Okay. Postsynaptic. At the dorsal horn of spinal cord, and it was 100% occupancy. It is 20% only, but it is able to inhibit GABAergic interneuron, which subsequently increases norepinephrine and ACH. Okay, I'm really sorry. I'm really sorry, not this. This will write somewhere else. This will write somewhere else. This will write just after this. This is in spinal cord, 20% occupancy, same. Hyperalgesia control. But if this receptor, 5-HT7 receptor, is in brain, okay, specifically in medial prefrontal cortex, there it does this action. There it does it, this action. Okay. It has also been found to increase interleukin 4, which is associated with increase in action of BDNF and hence anti-inflammatory and pro-cognitive. Are you able to get it? Whatever we have written as of now? Okay. So now, if you look into this, still the management of there is increasingly considered as a treatment option. Okay, it's a novel drug. Still, the results are coming up. Multiple pilot studies are going on. Okay, and if you look into the recent clinical pilot study, they are usually trying it for C chronic neuropathic orofacial pain, and the results were plus minus but promising only. Okay, remember this orofacial pain, CNOP. This was what they were trying to look for. So a bit of new development in Vortioxetine. You can write this up in the upcoming exams if they ask. Okay, I hope it was able to give you some insight regarding Vortioxetine, not only as an antidepressant, but also as a agent which can be used for pain, can be used for cancer also. But these are all preclinical things. I'm sharing that article with you. Okay, and remember this. This was an update. Okay, thank you for attending today's session.